We had a patient in our clinic the other day that has had fortunately, a very successful outcome from a procedure. And it made me wonder how many other people out there in the United States have the same problem. His pain began after a procedure that occurs hundreds of thousands of times, perhaps a year in the United States. And this middle-aged gentleman had what's called a colostomy, which is where we bring the colon to the outside of the abdominal wall through the rectus abdominis muscle, which is the six-pack muscles of your abdomen. And we do that because the colon itself is very diseased and you cannot have a bowel movement the normal way. This happens after diverticulitis, severe diverticulitis, or Crohn's disease, or any number of inflammatory diseases to the colon. And this is a life-saving procedure, but it's less than ideal, obviously, to have your large intestine come to your skin. Fortunately, this gentleman was able to have that reversed, and they rebuilt his colon so he could have bowel movements normally. But actually, once they repaired his abdominal wall, which you have to do to prevent a hernia, one of the cutaneous nerves, that means one of the nerves to the skin, got trapped inside of a suture. And so he had incredible pain that was basically electrical, shooting, shocking pain that radiated from his abdominal wall that he could put a fingertip on, literally put his finger right on it. And it zapped him into the abdominal wall, but then it radiated up to his back and to his spine. And everything hurt. For 5 years, he had pain. He had pain so bad that he couldn't have his children sit on his lap. He had a difficult time sneezing or laughing or coughing because anything that forcefully changed the abdominal wall would trigger that pain, because the nerve itself, which was, here's the nerve, was stuck by a suture. Every time he moved, he had lancinating pain. And so he was able to come to the office. We were able to actually identify that by his fingertip. It was not a diffuse abdominal wall pain. It wasn't pain everywhere. That's not the kind of pain we're talking about. We're talking about pain right there, doctor, on the scar that I have from my surgery. It's right there. And we were able to use ultrasound to put a needle in what's called the intercostal nerve. We were able to put numbing medicine in there. His pain went away within 20 to 30 seconds. That provides excellent support that that nerve that goes to that scar is stuck in the scar for some reason. It may be because the scar tissue got very dense. It may be because there's a stitch that's wrapped around the nerve. And these nerves are quite tiny. They're about 1 millimeter to 1.5 millimeters, maybe 2 millimeters if it's very large. And we don't see them very easily when we're operating. And so I'll show you what I mean. In the abdominal wall, there are these nerve branches that come to the abdominal wall. And this is the anterior cutaneous branch of the intercostal nerve. It's anterior because it's on the front, cutaneous because it goes to skin. But as you can see, this little nerve here goes through the rectus abdominis muscle, which is the six-pack muscles, okay, and then goes around to the spine. And if you close this layer of white tissue, which is called fascia, which you have to close or else you'll have your bowels come out, you can easily catch a stitch with a suture. And it can be from the colostomy, it can be a hernia repair, it could be from a gallbladder operation where they accidentally put the trocar through a nerve, which you can't see at all. It could be from any of a number of different operations that occur on the abdomen. But a simple stitch can be the source of a tremendous amount of pain. So in that patient, we were able to find the nerve here, follow it, and divide it on purpose. So we divided on purpose to tuck the nerve into a dark, safe place, into a healthy muscle, away from scar tissue, to try to prevent a recurrent sensory nerve neuroma coming back and causing him pain. And yes, you do lose the sensation downstream of that nerve, but this is not an essential area of your body. And already the area was numb anyway because the nerve had already been injured. So in this particular patient, he had very little, if any, additional numbness to his abdominal wall because the nerve was injured 5 years ago. And so our hope is that this video will bring a little bit of clarity and a little bit of hope to some people who have a colostomy takedown or a colostomy or any other type of abdominal wall surgery where they've had persistent, very well localized pain in their abdominal wall. Again, this approach is for patients who can literally put a finger right on their pain, and that pain may be associated with a previous surgical incision. And we can easily put a needle with some local anesthetic in it, see if it goes numb and the pain goes away. You can repeat that. You can use some steroids in it. If that does not work long term, you can go find the nerve and remove it. And so we're hopeful that if anyone out there is watching this video who has a friend or family member or even themselves who have pain associated with the surgical scar in the abdomen, that there will be some hope for you with improvement in the future. Thank you.